Hello, everyone. Thank you for joining today's briefing, Equity in Health Data, COVID-19 as a Case Study, a program of our signature series. I'm Serena Coates-Golden, Senior Health Policy Analyst at the Alliance for Health Policy. For those who aren't familiar with the Alliance, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. This event is the concluding part of a broader equity series featuring heavy hitters in health policy like CMS Administrator Chiquita Brooks-LaShore and Daniel Dawes of the Thatcher Health Leadership Institute, among many others. So far in the series, we've explored a multitude of factors, both current and historical, contributing to the current state of equity in the U.S. We address the trade-offs between inaction and intervention in many policy areas ripe for equitable approaches, as well as tangible policy options to start advancing health equity where we are right now. To make this happen and to bring today's briefing to you, the Alliance is supported by an impressive group of Signature Series sponsors. I want to take this moment to thank them again for their support. I'd like to remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy, as well as on Facebook and LinkedIn. We want you all to be active participants, so please get your questions ready. You should see a dashboard on the right-hand side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time. We'll collect these questions and address them during the. You can also chat any technical issues you may be experiencing, and someone will attempt to help. Please be sure to check out our website at allhealthpolicy.org, where you can find background materials, including speaker bios, a resource list, and expert list associated with today's event. A recording of today's briefing, including the slide deck, will also be made available on our website soon. And if you missed our Health Equity Summit on September 15th and 16th, we encourage you to visit the summit page on our website as well. Now, I'm pleased to introduce today's esteemed moderator, Ms. Nadia Siddiqui. Ms. Siddiqui is Texas Health Institute's inaugural Chief Health Equity Officer. She has over 15 years of experience designing and leading innovative national, state, local initiatives for advancing health equity. Ms. Siddiqui has served in data director roles for national data initiatives, including the HOPE Initiative and America's Health Rankings Health Disparities Report. She's worked with communities to co-design and implement culturally tailored health assessments and solutions. Previously, she's managed multi-year national projects on advancing health equity in health reform and public health preparedness, including the National Consensus Panel on Emergency Preparedness and Cultural Diversity. Nadia, thank you so much for joining us today. I'm happy to hand it over to you.
Thank you, Serena, for the warm welcome and kind introduction. And thank you to the Alliance for Health Policy for having me here today. I'm delighted and honored to serve as moderator for today's briefing. COVID-19 has put a bright spotlight on the gaping gaps in our health data systems, gaps that have existed for far too long and have hampered our ability as a nation to respond effectively to this pandemic, exacerbating inequities and outcomes at so many levels. At the same time, this pandemic provides an unprecedented opportunity to reflect, identify, fix, and build processes and systems that are equitable in collection, computation, reporting, and use of data. Ultimately, it is equitable policies and processes that drive equitable outcomes. This is why today's briefing is so important, and I'm honored to be joined by distinguished experts in the field to discuss challenges and opportunities in leveraging health data to make equitable care and policy decisions. And so I'm joined today by Ms. Samantha Artiga, who is Vice President and Director of the Racial Equity and Health Policy Program at Kaiser Family Foundation. In this role, Ms. Artiga leads Kaiser Family Foundation's work to provide timely and reliable data information and policy analysis on health and disparities affecting people of color and underserved groups to advance racial equity in health and healthcare. She also has conducted extensive work related to the health and healthcare needs of low-income populations and immigrant families, and previously served as Associate Director of Kaiser Family Foundation's program on Medicaid and the uninsured. Next, I'm pleased to introduce Dr. Khadija Ferryman, Assistant Professor at the Johns Hopkins Berman School of Bioethics. She is a cultural anthropologist who studies the social, cultural, and ethical implications of health information technologies. Specifically, her research examines how genomics, digital medical records, artificial intelligence, and other technologies impact racial disparities in health. Among her accolades as a postdoctoral scholar at the Data and Society Research Institute in New York, Dr. Ferryman led the Fairness in Precision Medicine Research Study. She examines the potential for bias and discrimination in predictive precision medicine. And finally, we are joined today by Dr. Ziad Obermeyer, who is Associate Professor and Blue Cross of California Distinguished Professor at UC Berkeley, where he does research and teaches at the intersection of machine learning and health. He has been named an emerging leader by the National Academy of Medicine and received an early Independence Award from the Office of the Director of the National Institutes of Health. With that, I'd like to hand it off to Ms. Artiga to start our discussion today.
Thanks so much, Nadia, and thanks so much to the Alliance for having me here for this important discussion. I'm going to spend some time today talking a little bit about what some of the key sources of data are for understanding health and healthcare disparities, and then some of the current limitations and gaps in those data, and using some examples of COVID-19 to examine those gaps. So if you can start and move to the first slide, please. Next slide. So just a little bit of background on my organization, KFF, or the Kaiser Family Foundation. We're a nonprofit organization that is focused on national health issues affecting America, as well as the U.S. role in global health policy. You can see that our work spans multiple areas, and Nadia already gave you an overview of our program area on racial equity and health policy and the work we do there. I'm going to be presenting much of the work we've been doing in this program area focused on COVID-19 vaccinations today, and all of that work is available on our website at kff.org. So if you're interested in seeing more after the comments today, you can find it there. Next slide, please. So as you know, today we are going to be talking about data, and I just really want to start by emphasizing how essential data is to overall efforts to advance health equity. We really need comprehensive, high quality, disaggregated data to have a complete and nuanced picture of the status of health disparities and who is affected by them, to understand how multiple intersectional factors drive health disparities. But not only is the data important for understanding disparities, it also is key then for addressing them. The data can be used to help effectively guide resources and efforts to address disparities and advance equity. The data is also key for then measuring progress toward our goals of equity and for establishing accountability toward achieving greater equity. Data can also be used to identify best practices or strategies to help inform spread of those practices more broadly. Next slide, please. So some key sources of data today for understanding health and healthcare disparities and guiding efforts to address them include survey data. So we have our major federal health surveys. There are also state, local, and private organization surveys. Outside of the survey data, we also have administrative data, including federal level data produced by the Centers for Disease Control and Prevention, the Centers for Medicare and Medicaid Services, among others. There are also state and local data sets that are available for understanding health and healthcare disparities. And aside from these survey and administrative data sets, there are also claims and clinical encounter data, although we're mostly going to be focusing on the survey and administrative data today. Next slide. So the federal government has established some minimum racial ethnic classification standards that apply to federal survey and health data sets. These were established in 1997. You can see them here that they establish several minimum race categories, including American Indian and Alaska Native people, Asian people, Black or African American, Native Hawaiian or other Pacific Islander, and white. Separate from the racial categories are then the ethnicity categories of Hispanic or Latino or not Hispanic or Latino. These standards were reviewed by HHS in 2011, and there were some additional subcategories that were added within these broader categories. And it is encouraged that additional granularity using those subcategories is used where it is possible in terms of sample size within the federal survey data sets. Next slide, please. So, despite these federal standards, there are a number of ongoing gaps and limitations in racial and ethnic health data. So I'm going to talk about what some of those major gaps and limitations are, and then we're going to look at some examples of those as we've seen in the reporting of COVID-19 vaccination data at the federal and state level. So the first is that there continues to be a lack of reported data that is disaggregated by race and ethnicity in some data sets. So this simply means there are some data sets that just don't report data by race and ethnicity, so that data is missing. Moreover, in many data sets, we see that there is insufficient data to report for smaller population groups, in particular American Indian and Alaska Native people, and Native Hawaiian and other Pacific Islander people. So those groups are often missing within the data sets. We also often are missing data to break out smaller subgroups of those broader racial and ethnic classifications that you saw on the earlier slide. We see a number of inconsistencies across racial ethnic classifications. So not all data sets use those same racial ethnic classifications that were established by the federal standards. So we'll see, I'll talk through some examples of the inconsistencies we see there in the COVID-19 data. One trend we've seen particularly recently is growing shares of people who are categorized in multiracial or other categories, really reflecting the increasing diversity of our population. I think this is an issue that is going to require increasing attention going forward in terms of the most effective way to classify people who identify as multiracial. As this group continues to grow, because simply lumping them all together in one category is not going to be helpful for analysis and understanding going forward. We also see incompleteness in data. So in many cases, race ethnicity may be reported, but is missing for a number of observations. There are also sometimes lags in data reporting. And sometimes the data are published in a way that don't allow for intersectional analysis across multiple factors. And again, I'll provide you an example of what that looks like in the COVID-19 vaccination data. Next slide, please. So let's start with some examples of these gaps and limitations by looking at the federal COVID-19 vaccination data that is reported by CDC. So CDC is reporting vaccinations by race and ethnicity at the federal level, but it is not currently reporting state level data that is broken out by race and ethnicity. So that limits really our understanding of variations in disparities across the country. Moreover, race ethnicity information is missing for nearly 40% of vaccinations that are reported by CDC, which really limits our ability to get a full understanding of who is and who's not getting the vaccine. Again, we also see relatively high shares of vaccinations that are categorized as being received by people in multiple or other racial categories. And the data are not reported in a way that allow for analysis by multiple demographic factors. So for example, CDC reports vaccinations by race and ethnicity and vaccinations by age, as well as vaccinations by gender, but you cannot use the data to examine vaccinations by both race and ethnicity and age at the same time. And as of our last, the time we checked the data, race ethnicity information was not yet available for booster shot recipients. Next slide. So because CDC has not been reporting state level data on COVID vaccinations by race and ethnicity, we at KFF have been conducting ongoing analysis of data that is directly reported by states through their dashboards or websites. So you'll see here that as of our last data collection, most states were now publicly reporting COVID-19 vaccination data that included race ethnicity information. However, there are still 3 states that are not reporting these data, so we don't have a full national picture. Next slide. In terms of other limitations, again, as I mentioned, one common limitation we see in data sets is lack of data for smaller population groups. And here you see in gray the number of states for which COVID-19 vaccination data is not reported for either American Indian and Alaska Native or Native Hawaiian or other Pacific Islander people. So the data for those groups are missing in those states. Next slide. I also mentioned that a common challenge we have is inconsistency in racial ethnic classifications. So here you see that there is large variation across the states in terms of whether they report race and ethnicity as separate categories or as combined categories. So states that report those as separate categories include Hispanic people in their racial categories. States that report a combined approach exclude Hispanic people from the racial categories and only include them in the Hispanic ethnicity category. We also see other types of variations. For example, some states combine Asian and Pacific Islander people into a single group, and some states simply only report Black, white, and other as their categories. So there's a lot of variation across states in these classifications. Next slide, please. And then again, we have the challenge of not having data reported in a way that allows for intersectional analysis in many cases. So again, using the example of being able to examine vaccinations by both race and ethnicity and age, we see that there are only a handful of states now that currently report data on vaccinations among children by race and ethnicity. And this is going to be a particularly important data point going forward as more children become eligible for the vaccinations, but we won't currently have data to be able to understand which children are and are not getting the vaccine based on the way the data is currently being reported. Next slide. So just to highlight some of the implications of these ongoing data gaps and limitations, again, they really limit our ability to get a complete and nuanced picture of who is and who is not getting vaccinated. The missing data, the data inconsistencies, and the inability to examine vaccination rates across multiple factors really limit our ability to analyze and interpret the data. And then in turn, this incomplete understanding and limits on our ability to interpret and analyze the data then hinder efforts to effectively direct resources and implement efforts to address disparities, as well as to measure progress in terms of addressing disparities over time. Next slide. And so I'll just close with a few thoughts on some priorities going forward for addressing these data gaps and limitations. The first would really be the prioritization of data collection and reporting as part of efforts to address disparities and advance health equity. Really working to increase the availability and accessibility of public data. Focusing efforts to expand the data that are available for both smaller population groups as well as subpopulations of those broader racial ethnic classifications. Modernizing data collection and reporting systems and structures where limitations in those systems and structures may be contributing to some of these data gaps and limitations. Increasing standardization of data reporting, particularly in the racial and ethnic classifications that are used to report data. And then conducting outreach and education to both providers and individuals and others who may be collecting data to help them understand the importance of reporting data by race and ethnicity and why reporting that data is actually helpful versus hurtful to help improve the completeness of the data where it is being reported. And with that, I'll close and shift things back to Nadia and look forward to the discussion.
Thank you, Samantha, for laying the context. I'm now going to turn it over to Dr. Ziad Obermeyer. Okay.
I'm happy to go now, but I think should we do Khadija? I think she might be up next.
Oh, absolutely. Let's turn it over to Dr. Khadija Ferryman.
Thank you, Nadia, and thank you for that, Samantha, for that excellent presentation. I think you did really lay out some of the limitations and challenges that we have with health data today, especially in COVID, with COVID-19 vaccination. Today, I'd like to, I'm going to address health data in the context of COVID-19, but I'm going to focus on data analysis, particularly AI as a health data computational tool. But of course, how you analyze the data, the tools that you use to analyze the data, and the data themselves are, of course, connected. So I'm going to start, as I said, with sort of thinking about artificial intelligence and how artificial intelligence has been used increasingly over the past few years to address, to analyze health data. And so I want to start with just a little bit of context setting in that although there has been increased attention to the use of AI overall in multiple domains, from finance to criminal justice, and in health, I would say there's been increasing attention to the use of AI in health over the past 5 years or so. The FDA actually cleared its first, or sort of approved the first AI algorithm in health in 2012. And that was for a chest imaging AI. So again, just to set the context that there has been increasing attention to the use of AI in health for the past few years, but AI in health has been under the FDA's kind of regulatory umbrella for a number of years, for almost a decade. So that was the first AI algorithm for health was approved in 2012. But today, that number stands at over 100. So currently, the FDA has approved over 100 AI devices for use in health. And so there are a number of different devices used for all different kinds of functions in medicine for different areas of the body. So like I said, even though the number of devices has been increasing over the years, and we can expect that number to continue to increase as we go forward, the policy development around how do we actually regulate AI in health is still really in the sort of developing stages. So the FDA drafted policy guidelines for the regulation of AI in health last year, particularly looking at types of artificial intelligence tools that are automatically updated. So this is really a kind of burgeoning area of policy development for the agency. And the current draft stage of policy around regulating AI tools in health, I think provides an opportunity for us to really continue to develop this particular policy arena. And I see opportunities in two ways. So one, the current policy around AI in health, again, that has been proposed by the FDA, I think provides an opportunity for us to really think about regulating AI in health, not just through technical considerations, such as how accurate these devices are, but really through socio-technical considerations, such as how accurate are these devices, not just in general, but across different demographic groups. How accurate are these devices in different kinds of healthcare settings? So the current proposed guidance really focuses on the kind of technical dimensions of regulating these devices, but I think the draft policy really provides us an opportunity to expand to socio-technical considerations. The second and related opportunity that I think this draft policy provides to us is to consider how the regulation of AI in health could change or could further develop if we think about developing these policies through a health equity lens. And what I mean by that is thinking about how AI devices, as they are applied in medicine, might exacerbate already existing health disparities, as well as how these devices could provide us with opportunities to facilitate and advance health equity. So that's sort of the overall context of AI in health regulation and policy, and sort of where we are and where we can go in the future. So I want to bring it down to a specific example that's more relevant to COVID-19. So there are at least 10 FDA-approved AI devices that analyze images of the chest and lungs. At least 10. There are more. And what these devices do is that they can, using images, they can identify cardiac and pulmonary disease, as well as triage cases for priority attention for clinicians. So these AI essentially will analyze images at rates of speed higher than humans can, and identify what might look like disease, and then set those images in a sort of priority for clinicians and be able to alert clinicians and triage some cases that demand more attention because something has been spotted on the images. So it's clear, I think, to see, right, how these kinds of devices that can spot cardiac and pulmonary disease and can triage cases for priority attention would be useful in our current context of COVID-19, because of course COVID-19 affects the respiratory system, right? So having a AI device that can identify pulmonary disease and triage cases for attention by clinicians would be helpful. But we also know that COVID-19 also affects other parts of the body as well. So these other devices that look at analyze images from other parts of the body can also be relevant in a COVID-19 context. But if we think about these devices, and like I said, I just want to think about imaging devices that use chest and lung images to identify disease and triage cases for clinician attention. I think if we think about those devices through a health equity lens, we should think about at least three things. So first, it is important to recognize that there is an already existing disparity between racial groups in imaging. So there is research that has shown that non-white patients receive diagnostic imaging less often than white patients. So just thinking about these tools and again, how they could be useful in a COVID-19 context, this tool itself may exacerbate this disparity if it becomes widely used again to triage patients, simply because there's a disproportionate percentage of images from certain groups that would be even available to be analyzed and triaged by these kinds of devices. So that's one thing that would come to the fore if we were thinking about the use and regulation of these devices through a health equity lens. Second, if we were thinking about these tools through a health equity lens, we would also be attentive to differences in thrombotic events between different demographic groups, and by that I mean events that have to do with blood clotting. I'm not a physician. Our next panelist, Dr. Obermeyer, is the physician here on the call, but there are differences between groups in kind of blood clotting events, thrombotic events. And so these AI devices, they can identify and triage patients based on, for example, there are a number of devices that can identify pulmonary embolism and triage patients based on their images that show, that there's a pulmonary embolism. However, there is some research, again, that shows differences in demographic groups. And in particular, there's some research that shows that African Americans are at a higher risk of thrombotic events, even without embolisms showing up on imaging. So again, the use of these kinds of AI tools might exacerbate a disparity. And again, there has been identification of pulmonary embolism as an important complication of COVID-19. So we can imagine a sort of use case here if these tools are being used, but if there are these demographic differences, that the use of this tool could exacerbate a disparity. However, on the other hand, as I previously mentioned, right, African Americans are more likely to have thrombotic events, and because pulmonary embolisms are an important complication, especially of people who are hospitalized with COVID-19, and we also know from the data that we do have, the non-perfect data that we do have, that Black people are hospitalized at disproportionate rates for COVID-19. These tools, these AI tools that can triage patients and identify pulmonary embolisms, for example, could actually be used to facilitate health equity, because they might result in Black patients being triaged or being put at a higher priority because of the use of a tool to spot pulmonary embolisms, right? So this is an example of a sort of set of tools that have already been approved for use. But I think that if we think through them again, think about these tools and how they can be best used through a health equity lens, a number of different issues rise to the fore. Like I said, there are some challenges and some limitations that arise, as well as some opportunities to use these tools to advance health equity. So I will stop there and turn it over to Dr. Ziad Obermeyer, who is really a trailblazer in this field of thinking about AI and health data and bias. So I will turn it over to you, Dr. Obermeyer.
Thank you so much for that lovely introduction, and for to both of our prior panelists for covering so many interesting and important themes around the reporting of data, which I think is really powerful because it's a way we hold people accountable, and around how we should think about evaluating those systems. So I want to build on some of the themes that Dr. Ferryman was talking about, and try to tease apart some very specific implications for how we should think about auditing and regulating artificial intelligence. And I want to start with a very concrete example, because I think that it really taught me a lot to work on this example. And it's almost, I think of it now as a bit of like a, I guess, a parable, because it's a short little story that has a lot of clear and far-reaching lessons. And so here's the setting that I want you all to picture. It's population health management. So health systems and insurers need to take care of a population of patients, both in terms of their health and in terms of their healthcare costs. And to do so, when you're planning and you're the person responsible for this population of patients, you know that you've got a couple of patients, some small fraction of patients that are going to get sick. And if you could just know who those people were, who these needles in your haystack are, you could get them help today and prevent exacerbations of chronic illnesses that are both awful for the patient in terms of health outcomes, but also very costly for the healthcare system. And so you've got a haystack, you need to find needles. The way you find needles is by looking ahead to try to figure out who's going to get sick. This is a great job for an algorithm. So doctors are not that good at looking into the future. Algorithms are great at looking into the future. They know what you're going to buy on Amazon. They know what you're going to rate that movie you just watched on Netflix. And that same set of tools can be used to find patients who are going to get sick. So algorithms are used ubiquitously for this. The parable that I'm going to tell you about is about a piece of software that's made by one company and sold to a lot of health systems, and that's used for 70 million people every year to make an important decision about who gets help. The market estimates of these algorithms is 150 to 200 million patients per year. So effectively, the majority of the US population is being screened through one of these algorithms. And that algorithm score is determining whether you get access to extra help with your health today to prevent these chronic illnesses. So we were interested in whether those algorithms were biased. I'll say more about why in a moment. But what we found was that these algorithms as a family, but the particular product we studied in particular that we had access to that we could audit, was extremely racially biased. What it was doing was it was prioritizing healthier white patients ahead of sicker Black patients for extra help with their care. And as horrifying as that was to us, it was very important to get to the bottom of what was going on and figure out where the algorithm was going wrong. And here's what happened. When you're trying to predict who's going to get sick, you actually can't just tell the algorithm, find someone who's going to get sick. That's something that we as humans can talk about, and you know basically what I mean when I say that, but algorithms are very literal. They need to predict a single variable in a data set for a patient. And so the choice that a lot of people made, both at the company whose product we studied, but at lots of companies in academic groups, in parts of the federal government, is to measure someone's healthcare needs with their healthcare costs. Now, that's not an unreasonable choice, because in general, when people get sick, they do go to the hospital and they generate costs. The problem is that not everybody who needs healthcare gets healthcare in this country and in many other countries. And when there's that wedge between needing healthcare and getting healthcare, you get lower costs for people whose costs should be higher, but aren't, because of lack of access to the healthcare system, because of racism and discrimination and how they're treated by that healthcare system. And so the algorithm was trained to predict costs, and it saw very accurately that Black patients cost less, and that's what it predicted. So that's where the bias came from. It was the choice to use cost as a proxy for health when cost is a biased proxy for health. So here are 3 lessons that we took from that story. The first one is almost a philosophical lesson, which is that we often get angry at algorithms, but the algorithms are just doing what we tell them to do. And so we should be getting angry at ourselves for telling the algorithm to do something that encoded racial bias and other kinds of bias. The way we teach algorithms is an instantiation of our values, of what we think is important. And when we measure health with healthcare costs, we're teaching the algorithm that the only people whose health needs matter are the people who go in to see a doctor and get care for those health needs. And neither we nor the algorithms ever see the needs that never get met and that don't generate dollars. And this isn't just algorithms, because this is very, very common in health and in lots of other places. And if you don't believe me, you can look at the way the CARES Act, the CARES Provider Relief Act, distributed funding to hospitals. What it was supposed to do was help hospitals that needed help with their finances, with providing them finances to care for patients with COVID-19. But how did we actually give the money out to hospitals? Proportional to hospital revenue. So what value does that instantiate? Well, hospitals that make more money get more money. And that was our choice as far as how to distribute these billions and billions of dollars of funding in the midst of a terrible pandemic that was already exacerbating inequalities. So this is not a story about algorithms. Algorithms are just doing what we tell them to do. So that's the first lesson that I took from this. The second lesson is that when you look in the academic literature, but also in the literature on regulation and policy about how we should regulate algorithms, it's a really important issue, because as our work showed, the algorithm that we studied was able to get to huge scale, affecting tens of millions of people every year. No one caught it, not the manufacturer of the algorithm, not the hospitals who bought it, not the doctors or patients who applied it and were affected by it. So there's a clear case for regulation, but we don't have a clear vocabulary for how to regulate algorithms. And I think that, to use Elizabeth Warren's example, when we regulate a toaster oven, we know that that toaster oven should not explode. When we regulate a drug, we know that that drug needs to do more good than harm. What do we regulate when we're regulating an algorithm? And there's a ton of, there's just this huge variety of measures that's incredibly confusing, I mean, to me as an academic researcher, and to lots of other people. So let me propose one thing from this work that I just told you about that I think for me really helped me think about how we should be in the business of regulating algorithms. The algorithm is supposed to affect the decision. So in the case that we studied, the decision of who gets help for their health needs. So what should the algorithm be providing to that decision maker? Well, it should be providing them information about someone's health needs. Once we've articulated that, we can say an unbiased algorithm would be providing information in an unbiased way about health needs to the decision maker. So we can look at the algorithm score, and then we can just look at the health needs for Black patients, white patients, poor patients, rich patients, whoever we're interested in, and we can hold the algorithm accountable on one simple measure. We don't need to open the black box of the algorithm any more than we need to open the black box of the toaster oven or the drug that's being approved. We just need to know, is it doing what it's supposed to be doing? And is it doing that equitably for Black and white patients alike, or for any groups that we're interested in? The last lesson that I wanted to share with you is an optimistic one, which is that this bias that we found in this algorithm, as well as biases we found in algorithms in many, many health systems, insurers, tech companies, that bias, everywhere we found it, is fixable. Because once you articulate what the algorithm should be doing, the information it should be providing, not only can you hold the algorithm accountable for doing that accurately and equitably, but you can also retrain the algorithm to provide that information. And so in that original case study that we talked about, we actually worked with the company that made that algorithm, and we created a revised version of the algorithm that predicted not someone's costs, but actually a variety of measures of their health needs. And in doing so, we reduced the bias in that algorithm by 84%. And we found similar results in lots and lots of different settings with different partners in the healthcare sector, but also outside of health. So I think that this way to think about what should the algorithm be doing, is it doing that accurately and equitably, is really for me the key that's driven my understanding of algorithms and how to think about them, and that we're also applying in our work with multiple state attorneys general, as well as in conversations with federal regulators at the FTC and other places that are charged with consumer protection. So let me stop there and look forward to a discussion around that.
Thank you so much, Dr. Obermeyer, and the rest of the panelists. Starting with Samantha, who helped lay the context from a broader perspective, to Dr. Ferryman and Dr. Obermeyer really taking a deeper dive into the scope and breadth of AI and that it's fixable, the biases that are built into some of these systems. So thank you for that. Now I'd like to turn it over to our audience to answer questions. Please remember that you can use the questions panel of the audience interface to submit your questions at any time. As the questions start populating in the queue, I want to start with a few opening questions to our panelists. I'll start with this question around, should we have a baseline for what is equitable in terms of data collection and computation? And if so, what would that baseline look like? And how does that translate into workflows? Anyone want to take that on?
I'm not sure I can fully answer that question. I will say, I mentioned what the current federal standards are around racial ethnic classifications that apply to many of the federal health data sets. I think, again, those were established in 1997. I think there is room to be revisiting those standards to see whether they are effective for our population today. As I mentioned, I think it's going to be increasingly important to be thinking about how we identify people who identify as multiracial, and how that data is then classified and analyzed, particularly as that group grows, as our population becomes more diverse. If we continue to put all those people in just an other category, that's not useful for understanding the diversity of people's experiences. So I think there's some important thought that needs to go on there. Again, I would highlight that we really today still miss a lot of data to be able to understand the experiences of smaller population groups and of subpopulations of the broader racial ethnic categories. In particular, that broad Asian classification includes just such a huge diversity of people with different ethnicities and different experiences and different levels of health disparities. We see that across all the racial ethnic classifications, those broad groups mask a tremendous amount of underlying diversity within them. So really, with the increased attention and focus on understanding disparities and addressing health equity, I think there similarly needs to be real attention to getting high quality, comprehensive data that reflects everyone's experiences and not and doesn't leave out the smaller population groups, and that really allows us to understand the diversity of experiences across different communities.
Yeah, and I totally agree with everything that Samantha just said, and I would just add one thing which all of our speakers have talked about already, is to, when we're thinking about data collection and analysis, and it sounds really simple, but I think it's worth just emphasizing and saying again, is point one, starting with the agreement that the data and the analysis that we're doing is happening in a context of health that is not equitable, right? That there are health disparities, that the data that are being collected are reflective of a number of disparate measures in terms of treatments, who is getting access, what healthcare institutions look like. And like I said, this sounds simple, but I think often that is not at the starting point. So I think if that is a starting point, right, the sort of ground truth that sometimes, you know, we hear engineers talk about, right, like how can we develop the ground truth for these algorithms? I want to say that the ground truth should be that the you know, healthcare is rife with disparities, right? We have enough evidence from you know, so many years to be able to establish that as a ground truth. So I think that's kind of the starting point, right? And then where we go from there in terms of both data collection and analysis is that what that means is in order for data collection and analysis to be equitable, then if we recognize that sort of health disparities are our ground truth, then those data collection and analysis measures and tools are going to look different depending on the health disparity that we're talking about, depending on the group that we're trying to collect data about, right? So standards, I think, are useful, but we in some cases, right, we may need to collect, we may need to oversample and collect more data on certain groups, right, depending on the disparity or the sort of health context that we're looking at. So I think if we sort of start with that as our ground truth and recognize that different kinds of diseases, conditions, things that we're sort of interested in collecting data about and developing tools for, those will look different. Our needs will be different. Our standards may be different. That's the way that I think we can begin to move towards equity.
I really love both of those comments, and I saw one common strand that I just want to tie together. So, you know, Samantha mentioned this really important thing about representation in our data sets and representation of all of the different groups that we're interested in, even if they're small. And I think, Khadija, what you said is that, you know, it's not just about like a counting exercise of people, but it's also about the, you know, the ground truth that we're learning from. And so even if we have, for example, representation, and we have this in all of our COVID statistics at the national level, we collect data from lots of poor and Black counties, and that might look great to you. But there's this other problem, which is that, what do we mean by COVID? How do we track COVID cases and COVID deaths? Well, we track it because people get tested for COVID, and we count that as like COVID. But we also know that lots of people don't have access to testing for COVID. And so now those people don't show up in our measures. So there's this, like, we see the tip of the iceberg of the COVID cases that are diagnosed, and it's very tempting to treat that as the ground truth. But that's not the ground truth. And in fact, the reason it's been so hard to predict COVID is because we're missing that whole bottom part of the iceberg of undiagnosed COVID that, you know, is spreading without us tracking it, but it's still killing people and it's still doing so much damage. So I love both of those dimensions of, you need to, of course, count people and make sure that your data sets are representative, but you also need to make sure that your ground truth acknowledges all of these inequities. But there's a mathematical formulation of that, which is, there is a variable that I don't observe, which is true COVID. I see this biased version of it, which is measured COVID. Now I can start to adjust for that. And I think it reminded me a lot of our health versus healthcare costs problem, because you see that similar issue with proxies in a lot of cases. We never measure the thing that we really care about because of all of these structural disparities, but we can work around that and we can undo some of those biases.
Yeah, thank you for those responses. I want to pick up on two comments that were made earlier and pose this question that came in. You know, one, that there are two sides really of the coin when it comes to AI. It can be used, it can exacerbate disparities, right? But it can also be used as a tool to advance health equity. And then, Diab, you brought up the point about the distribution of the CARES Act funds that were proportional to hospital revenues. And so the question I have is really around healthcare institutions. How can we be sure that whatever health data policies are recommended or implemented do not further marginalize these under-resourced healthcare institutions or safety net providers that serve historically marginalized populations. Any thoughts there?
I'll just contribute one brief thought, which is that right now, when you look around at not just healthcare organizations, but any organization that's applying algorithms at scale, there is shockingly little oversight of those algorithms at the institutional level. So the decision making is often pushed down to a clinical department or to the IT team, or it's very decentralized. And I think let's say that let's bracket bias. Let's say you didn't care about bias at all. These tools are affecting tens of thousands, hundreds of thousands of your customers, your patients, and there's no strategic oversight about what they're doing, where they could be going wrong, are they doing what they're supposed to be doing? So there needs to be like a C-suite person whose job it is, or is part of their job, to oversee algorithms, both to make sure they're doing what they're supposed to be doing, but also to make sure that they're unbiased and equitable. And part of that is actually doing an inventory of all of the algorithms that are being used. Most organizations have no central repository of what algorithms are being used, how they're performing for different groups. So I think in one of the resources that I think are being shared along with this webinar, we wrote what we called, for lack of a better word, a playbook around algorithmic bias, which was a document that tried to synthesize lessons from dozens of collaborations that we've had with real health systems, real insurers, where we've audited algorithms and tried to write down what worked at those organizations, establish an oversight structure, inventory algorithms, keep documentation so that if a state attorney general comes asking you about the performance of your algorithm, which they will start doing soon, you don't look like an idiot, and you actually know what those algorithms are doing, how they're performing, and whether they're doing it equitably. So there are these very simple things that that are really, really important for organizations to start doing, and we try to lay those out in that document.
Yeah, and I think those are really great suggestions. And I would just also add to that, right? I think it's really important for healthcare institutions to sort of know to have algorithmic evaluation on their radar as part of the other kinds of things that they are evaluated on, right? Like healthcare institutions are no strangers to being evaluated and having formal evaluation processes. So in some ways, there could be fairly, there could be, I don't want to say fairly simple, but there could be ways for this to be sort of be integrated into practices that already exist for kind of system-wide evaluation. However, I think it's also important, for not just the stick, but also the carrot, right? So we could also think about ways, maybe it's through different kinds of reimbursement structures where healthcare institutions might be rewarded for having unbiased algorithms or showing performance that their algorithms have decreased health disparities between groups, right? So, maybe there are other ways to sort of bring about those kinds of changes, right? One, through a kind of institutional evaluation process, and maybe through, from like payers, right? To sort of say, well, there could be incentives for you to make sure that your algorithms are really doing what you say they're doing and are proactively addressing some of these longstanding issues.
Thank you for that. I'm going to turn us to, there seem to be a series of questions around, why there may be a lack of data reporting. And Samantha, I think I'm going to pose this more to you as you presented some of the COVID-19 vaccination data. Why do you think there's a lack of data reporting? Could it be due to a lack of resources, tech capabilities for state public health programs, or how some states have attempted to roll back public health abilities?
So I think, really it ties back to lack of prioritization of this reporting and collection of data. So really right now we're in a time where there is very heightened attention and focus on health disparities and efforts to advance health equity. while we have documented health disparities for decades now, there has not always been this level of attention and focus. And so I think a lot of the gaps in data reporting just reflect lack of prioritization of having the data available by these different factors, including race and ethnicity, to understand disparities and address them. So that, I think, is really kind of the starting point there. Is there needs to be an intentional focus and prioritization on having these data available. That lack of prioritization then carries over into the other factors that you mentioned. So maybe the systems were not designed to collect data this way. Maybe the resources were not deployed to properly collect the data. I think also one of the comments I made was that there is incomplete data, which I think reflects both lack of prioritization among people collecting the data to explain why reporting that demographic data is so important and helpful, as well as a lot of hesitation on the part of individuals reporting the data who maybe historically reporting that data was not helpful to them. Often that data has been an optional data field when you're reporting on multiple things, inside and outside of healthcare. So helping people to understand, again, why reporting that data is useful, important, and potentially helpful to them, I think is another component of this. So I think it really is the prioritization, having the resources available, making sure the systems and infrastructure is there, but then also communication and outreach to both the people who are collecting the data and the people reporting the data to help enhance the completeness of the data going forward.
Yeah, and those are great points, Samantha. And building on that, and this is for all the panelists, there's a question of cost and cost implications that's come up to correct, for gaps in data reporting and collection, to fix for biases. And then the specific question is, are there cost issues with adding categories to data collection? And are the agencies and organizations that you're talking with willing to spend the extra money required to get the additional information? I know, Khadija, you mentioned, incentives as well as a way to implement some of these processes. But are there other thoughts about costs and cost implications?
I had a quick one, which is that insurers get a lot of data. So one of the big problems that we've faced when we're working with insurers that only have claims data is that they don't often have a lot of demographic information about people. But that is a weird fact, because these insurers get a ton of data from hospitals and providers, and there is no reason that they cannot also ask for demographic information along with all of the other data that the hospitals are sending them. The reason that they often don't is because they would, in some cases, rather not know about disparities. And there are a lot of legal implications for disparities and treating people different. So I think the dominant view in a lot of legal departments is that they'd rather not know. And I think that one note from the work that I've been doing with regulators at the state and at the federal level is that that is a bad defense when someone comes asking about bias, is to saying that we've never looked into it is actually not protective, and if anything, it looks worse. And so I think that in many cases, that there's this general principle that it's not the crime, it's the cover-up that's the problem, and I think that principle really applies here too.
Well, thank you so much, panelists, for your insights and for the rich conversation that we've had today. Unfortunately, that is all the time we have today. A few quick notes. I'd like to thank Sarah Dash and the Alliance for Health Policy for inviting me to moderate today's session. I'd like to acknowledge Serena Coates-Golden and Bailey Wilbanks from the Alliance Policy team, and Serena Katz on the Alliance External Affairs team for their behind-the-scenes contributions to make today's event possible. Audience members, please take the time to complete the brief evaluation survey that you will receive immediately after the broadcast ends, as well as via email later today. If you'd like to learn more about other foundational health policy concepts, download the Health Policy Handbook available on the Alliance for Health Policy's website. And please join upcoming events on October 29th for a briefing on policy options to advance mental health care during pregnancy, as well as November 3rd for environmental health briefing on introduction to environmental health and health policy. A recording of this webinar and additional materials will be available on the Alliance's website. This concludes the Alliance for Health Policy's Health Equity Signature webinar series for 2021. Samantha, Khadija, Ziad, thank you so much for joining us today. Thank you.